Good afternoon, everyone. I hope you're having a great day. On behalf of ACIOE Associates, I would like to welcome you to our third health webinar on lessons from the COVID-19 epicenters in Nigeria. Today's webinar will highlight strategies adopted at national and subnational level to fund the COVID-19 response in Nigeria. Our thoughts and prayers are with those who have lost loved ones in this period. We would like to thank all our participants for taking the time out to be with us today. We also thank all our panelists for taking time out of their very busy schedules to join in our discussions today. ACIOE Associates is an advisory services firm providing solutions in strategy, government relations, regulatory affairs, economic development, advocacy, investment facilitation, and policy analysis. We have supported government, development partners, and institutions to develop sustainable solutions to the challenging economic and development issues within the countries we operate. Our strength as an organization lies in the strategic relationships we have built with key stakeholders in government at national and subnational levels, and within critical sectors of the economy, including health, agriculture, energy, fast-moving consumer goods, and human capital development. At the onset of the pandemic in Nigeria, we met with our clients and stakeholders to understand how best to create value for them during this period. Also, noting the effect of the pandemic on the Nigerian economy, its communities, and the common man, it became important to streamline our work and ensure that we were contributing to the national and subnational COVID-19 containment efforts. To this end, we began to provide daily updates to our clients and key stakeholders on the effect of the COVID-19 pandemic on Nigeria's social, political, and economic landscape. These updates have helped our clients make quick and effective business decisions during these challenging times. To ameliorate the effect of the pandemic on the health and socioeconomic well-being of the vulnerable population, we have also coordinated the direct distribution of palliatives and hygiene products to the underserved communities in Abuja, the Federal Capital Territory of Nigeria. To support ongoing COVID-19 containment efforts at national and subnational level, we have facilitated partnerships between the private sector and the Nigeria Center for Disease Control, as well as the Federal Ministry of Health. Recognizing the growing importance of sharing lessons from the COVID-19 epicenters in Nigeria, we have decided to host webinars as a platform for stakeholders to share unique strategies adopted and lessons learned. Today's webinar will be the third in the series and will have the following outline. We will begin with an introductory presentation from Dr. Ajiboye. We will then dovetail into a panel discussion to be moderated by Dr. Olumide Okunola. Our panel today is made up of distinguished speakers who have coordinated and led funding of the COVID-19 response at national and subnational level in Nigeria. Following the panel discussion, there will be a question and answer session during which panelists will entertain questions from participants. Please feel free to submit your questions via the question icon on your screen. After this session, Ekene Misiche, the managing partner, ACIOE Associates, will give the closing remarks. The webinar will last for approximately 2 hours. Once again, we thank you all for your time and we look forward to your questions. I will now hand it over to Dr. Ajiboye for his introductory presentation. Thank you very much.
All right, thank you so much, Bami. So I will go straight into the presentation, basically talking about World Bank support to the COVID-19 response. My presentation will follow this outline. Basically, I'll give a synopsis of World Bank support, including on other essential health projects, talk about newly approved COVID preparedness and response project, the components of the project, the eligibility criteria, the process for assessing fund, and as well as the accountability mechanism and the status of where things are under this project and the REDISSE II project. So essentially, to give you an overview of what bank supports, I think when the first case of COVID-19 was confirmed in Nigeria late in February this year, luckily the bank had ongoing support to the government of Nigeria through the Regional Disease Surveillance Systems Enhancement 2 project. I will refer to it as REDISSE II going forward. Basically, since 2017, the World Bank has been supporting the government of Nigeria to respond and prepare for pandemics and strengthen the country's system in response to this. So the project had been approved far back as 2017, and it's a $90 million project. As at the start of COVID response, there was about 82.5 million left there, basically working through the Nigeria Center for Disease Control as well as the Federal Ministry of Agriculture. So far, about 34 million has been committed on it, of which 15 million has been spent and about another 18.7 committed. So what we have left on that project is roughly under $50 million. On the Nigeria COVID-19 Preparedness and Response project, it's the recently approved project, was approved August 6th, just about last week. Is yet to be effective. It's $114 million and is largely supporting states. I will talk a lot more about this project during this presentation. So essentially, it's a credit of 100 million and a grant of 14.28 million. The 100 million, the total, from the total sum, most of it, about $90 million, will be ungranted to states. So largely, it will be supporting state level response to COVID-19. Also in the kitty, we have quite a number of other projects that will support primary healthcare generally, like the Nigerian State Health Investment Program that should be ending about September this year. We have about 25 million undisbursed on it. It was a 315 million project. We have the Impact project, which will support malaria and across a number of states. It's 650 million, and then we have the polio program, and then 71 million lives program, and the other programs listed there. Essentially, the two projects that are largely supporting the COVID-19 response are the REDISSE II project and the Nigeria COPREP project. So the way we've designed it, we've structured it rather, is that the REDISSE II project will provide immediate support to the pandemic response plan at the national level. So things that needs to be procured at the national level to strengthen state level activities or state level response will be done through this project. The PCU is located within the NCDC, and that will be further strengthening to also coordinate the Nigeria COPREP project. In addition, the REDISSE project will provide support to states. So already all the states of the Federation, about 29 of them, you see that later on, have received about 100 million naira to support their immediate response to COVID-19, while the remaining are still in the process of receiving them. So all states are actually eligible for 100 million naira to support state level response. So basically, REDISSE II supports national level response. For the COPREP, we focus a lot more on the state level response. Seeing the gap that quite a number of states, perhaps all states, have COVID cases, but they are not able to adequately prepare and respond to this. So this project is supposed to fill that gap. So all states will be eligible. There will be clear eligibility criteria that states need to meet before they receive funding, which will be given to them in tranches and allow them to report, on spent fund before they get more funds. It's going to really be structured around financing their state incident action plan. And then eligible expenditures at the state level will be agreed upfront. So they will develop the state action plan, and the eligible expenditure will be agreed upfront before funding goes to them to ensure that accountability is improved on the project. Next slide, please. Next slide, please. Yeah. So talking a bit more about the COPREP project. Where there are two components, right? The first component, COVID-19 response, has two subcomponents. The first, that's component 1.1, basically is to provide federal level support. Really about 14.28 has been earmarked to finance things around, laboratory equipment, medical equipment, medicines, and all of those that need to be bought centrally and given to state based on needs. Then component 1.2 rather, which is direct support to the states, would largely, as I explained earlier, on go to finance the state incident action plans, and it will be shared about equally. The allocation is equal amongst all states. With the understanding that if there are states that do not disburse or spend as appropriate, the steering committee of the project can take a decision to reallocate funds in the future. So essentially, it's going to finance a wide array of things around the EOC centers to be established, investigations and contact tracing, risk management and surveillance, data analysis, laboratory and laboratory testing, and sample collection, training, equipping and furnishing and renovation of isolation centers, including the community support centers. We're not building new isolation centers from this project, but you can renovate existing isolation centers. And then this component will as well support issues around water, hygiene, and sanitation, given the central role it plays in the control of infectious diseases such as COVID-19, and as well promote community mobilization, risk communications, and around that. The component 2 has 2.1 and 2.2. 2.1 will essentially focus on coordination and project management, whereas 2.2 we talk about monitoring and evaluation, as well as the research agenda, which we largely funded from this. So, like I did mention, all states are eligible to receive funding on this, but they need to meet certain criteria, and those are really one, establishing the EOC and ensuring that there are clear roles and responsibility of the incident manager. The state action plan needs to meet technical guidelines that were provided by the federal government, so as to ensure that the direction that it needs to be, there's guidance, and everyone is really approaching it in a scientific manner, and as well as adapting it to local context. So the federal level actors, NCDC, will set the tone for that. States needs to sign an MOU with NCDC, basically on the use and reporting of funds. So it's not slush fund. It's specified. It's for specific expenditures, and then they need to sign an agreement based on that. And then state will adopt appropriate strategy that will be provided from time to time by NCDC, as well as there will be designated fiduciary officers to ensure proper use of funds. These are like the eligibility criteria, but there are also ongoing implementation of obligations, both on the FM side and the data reporting side, using SOMAS, for instance. The states, on the FM side, the states will need to provide full documentation to support expenditure on the first tranche before they receive subsequent tranches. And then in terms of implementation progress, a number of things that they need to do around, appoint and maintain a minimum number of functional rapid response team, ensure that the state EOC provides complete and timely data reporting, using SOMAS, establish and maintain a functional call center, designate at least one accredited lab for the purpose of conducting COVID-19 tests. So each state needs to have a lab that at least they can conduct a test on COVID-19. And then lastly, establish an adequate number of sample collection centers to ensure that these things are done professionally. So how do states really access funds on this? I tried to simplify the process here. So essentially, states need to prepare an incident action plan in line with the template provided by NCDC. I think there's already quite some experience with the states now, having received the 100 million naira under the REDISSE financing, which was basically to test the pump and prime the pipes for the bigger Nigeria COPREP project to states. So once they submit an incident action plan, they open an account as well, and then the states IAPs are evaluated by the COPREP PCU as well as a team of development partners, Nigerian Governors Forum. Basically, the National Technical Committee representatives will evaluate the plan submitted by the states. Upon evaluating this, there will be room for feedback so that they can improve on this plan, and then the PCU then recommend these plans to the National Technical Committee, which essentially it's chaired by the Director General of the NCDC, but has membership. The National Coordinator of the PTF has directors from NCDC, relevant directors there, directors also public health, hospital management from Federal Ministry of Health, has the IERD, that's the International Economic Relations Department from the Ministry of Finance, and a couple of others there to really guide the running of the project. So once they approve it, that is sent to the World Bank for a no objection. Is an IPF. So normally you would have World Bank no objection on this, and then once that is given, it triggers disbursement, and then the grant agreement would be signed by the state. Thereafter, money will be disbursed as appropriate. A couple of criteria here, perhaps if there are a number of states here present, that will be used to evaluate the IAPs that are submitted. And NCDC and the team that works with NCDC would evaluate, looking at alignment. Does this align with the prioritized activities? Are they using a template that has been provided by NCDC? Is the costing appropriate, and the unit costs, are they in line with reasonable limits? Are all sources of funding, because we don't want duplication of funds. You need to, as a state, you need to also make open all the sources of funding from other development partners and government and all of that, so that we're not double funding or double dipping. Is there value for money on this? With regards to the budget, is the funding request within the stipulated? Well, sorry, this is actually the 100 limit is 100 million limit is actually for the REDISSE project. For the COPREP project, is a lot more. It's 90 million between 36 plus one, $90 million between 36 plus one states. And then, if in developing the plan, if there's been adequate consultation and stakeholders engagement. Next slide, please. So in terms of the fund flow and accountability, fund will be managed by the state PCU, headed by the state epidemiologist. So the state epidemiologist will be the project coordinator at the state level. Of course, there will be a steering committee headed by the Commissioner for Health at the state level, along with other commissioners, Commissioner for Water Resources, Budget and Planning, as well as the executive directors of the State Primary Care Development Agency, the State Health Insurance Agency, and a number of others who would provide oversight to the state epidemiologists. So once the first tranche is released and up to 50% is utilized, the states can request for further funding, but that would be with full documentation, supporting the earlier expenditure, and as well as reporting on progress in terms of implementation as well. To promote accountability, which is really a key issue when you transfer this kind of money to state, a number of mechanisms have been adopted, and I will just quickly list some of them. One is transparency of state actions. So utilization reports, both financial and non-financial, will be put online by state and NCDC. Transparency of federal level actions, all criteria for making decisions will be published online. For instance, like the eligibility criteria, the evaluation criteria, so that it's clear what is being done. There's a proposal for the use of third-party monitoring agents that will be engaged by NCDC, as well as NCDC having a number of additional staff who would oversee activities or supervise activities at the state levels. And then we're robustly engaging with development partners who have presence across a number of states, virtually all the states, to also help with monitoring and validation of state level action. So it's a robust mechanism that has been put in place. In terms of where we are with things at this point, specifically on the REDISSE II project, as at yesterday, I think all states have submitted their incident action plans. 36 states have been cleared by the World Bank, of which 29 of them have so far received the 100 million naira each. 4 states are yet to provide account details, so they haven't gotten their money, whereas 1 state just submitted the signed agreement, and we're waiting for 2 other states to submit theirs. Since, like I did mention, this is like priming. The bigger funding will come in for the states through the Nigeria COPREP project, and what is really, that project has been approved by the board of the World Bank on August 6th. What is remaining now is to sign the financing and grant agreement. Like I did mention, financing IDA credit is about 100 million on this, and there's a grant of 14.28 million. So those agreements need to be signed, and a legal opinion issued by the Ministry of Justice. Once those are done, the project becomes effective, and money can start flowing to the state. Just to mention quickly that there's a provision for retroactive financing. So actually, the project actually makes provision that before this project becomes effective, if there are expenditures that are made by the World Bank, by the government of Nigeria, that follows the procurement process, on the project being effective, these monies can actually be paid back. I think I will stop here at this time. Thank you, ladies and gentlemen, for listening.
Thank you so much, Dr. Ajiboye from the World Bank. I think one of the key takeaways from your presentation is the fact that there's pretty a huge pot of funding available for states to fight the pandemic. And those are the things we will be unpacking today. But financing COVID-19 is not just public financing, it's also private financing. So welcome everyone once again. Perhaps this is one webinar that has brought together in one sitting all of the relevant people in Nigeria's response to COVID-19. And as you can see from the flyer, we really do have a really distinguished panel. Without much ado, I'm going to take my first panelist, Dr. Chikwe Ihekwezu, who is the Director General of NACA. If this were an in-person workshop, we would actually be giving you a standing ovation to yourself and your team. I enjoyed reading your article in This Day a few days ago, where you described what it has been like in the last 6 months since the 27th of February, when Nigeria declared its first case. So this is a financing webinar. First question to you. How has it been thus far? And I would like you to dovetail that into, has money been a problem in fighting the pandemic in Nigeria? Over to you, Dr. Chikwe.
Thanks, Olumide, and good afternoon, colleagues. Thank you for sparing some of your time to join this webinar. And thanks for a very kind words, Olumide. I think to start with, let's look at how much value, because people only spend money, and this is the same for governments, families, companies, on things they value. So the first thing we must all ask ourselves is, what value do we place on health security? You know, I've gone around this country before we started before this era. You know, you look for the office of the Director of Public Health or State Epidemiologist in an average state in Nigeria. I often found them when I started at, in a dingy small corner, sometimes without light, in a state secretariat. This is not by no means representative, but this is an example. with no laptops, no resources to work, you know, almost nothing. And this was the same for NCDC in 2016. We had a total capital budget at NCDC in 2016 of 400 million naira altogether, of which we got a release of about 30%. So the total capital resources with which we had to work in 2016 was 180 million naira to supply reagents, laboratory equipment, EOCs, surveillance for the entire country. So the first thing is this is an existential question for us, because we are not in a context where we have an excess of resources. There are lots of demands of our time. People are expecting us, federal government, state governments, to build flyovers, infrastructure, security. How much value do we place on something as intangible as health security? And that is the biggest question I have asked my own leaders, because the total capital budget for NCDC up to last year had only once exceeded 1 billion naira. Last year it was down to 1 billion again. It rose to 1.5 in 2019. So that's the first question. How much as a society, collectively, do we want to put into something called health security? So in the absence of sufficient capital allocation in the beginning of my tenure, you basically became an entrepreneur in government, looking around for resources to start your work. So, and that's basically what I spent the first 2 years of my tenure doing, looking for partners, begging on doors, private sector, public sector, you know, development partners, trying to explain to people that, listen, you must invest in this threat, even if you can't see it. But, you know, in most places, it wasn't considered a priority. So I was extremely grateful for the REDISSE opportunity that had started evolving before I started, but had stalled because of issues around providing governance structures, accountability. So we focused very hard at NCDC to convince all our partners that, listen, we will be a different type of agency in the public sector. We will be transparent. We will be accountable. We will put those processes in place. We will open our doors. We will carry out the first thing we did in 2017 was a joint external evaluation. A joint external evaluation is when you open up your institute to your peers. So you invited in WHO, other national public health institutes to come in to NCDC and look at how we're working. And, you know, we got a fairly low score of 39%. But listen, it's better to know how bad you are than to go around praising yourself that you're great, while, you know, the reality is that you're not. So we had this joint external evaluation. We came up with a 39% score. We said, listen, this is where we are as a country. We've got to build from here. So we started looking for resources. Partners came in from all sorts of places. We worked with the Federal Ministry of Health and the National Assembly to ask that half of the 5% that was set aside for medical emergencies should be dedicated to public health emergencies. And the Minister of Health at the time accepted that recommendation. And if you look back to the 2018 guidelines of the Basic Primary Healthcare Development Fund, you will find that 2.5% of those funds were dedicated to public health emergencies. Unfortunately, that 2.5% has been removed from the 2020 guidelines for whatever reasons. But, you know, we continue to push, and that is why now there are resources coming into health security. In every opportunity I've had to speak, I say I have two responsibilities right now in terms of resources. One is to make sure that we have the resources available for the response. And yes, resources have come in to NCDC from the public sector, from our president, from the private sector. COVID has been probably one of the most innovative approaches to funding health security anywhere in the world ever. So there has been incredible innovation, incredible support. Now, REDISSE has really quickly, the World Bank came to our aid, we restructured REDISSE, made sure that we had funding available to carry out some immediate needs, and also planning for the new project. So yes, right now, we do have resources to respond, but at the back of my mind every day is how do I ensure that there are 3 S's. stable, sustainable, and substantial funding for health security in the future. You don't fight a fire when your house is on fire. You prevent fires long before that happens. And it is at that point that people are least interested in funding health security. So let me end by saying, because I want to keep it short and open up to questions, that yes, the funds coming into the work we're doing right now is public knowledge. This is not the challenge. The challenge is this outbreak will come to an end, just like Ebola came to an end, just like all the others come to an end. The issue that all of us in this room who are leaders in our different sectors will have to ask is, how have we leveraged on this crisis to build our health security in the future? Do we send our NCDC team back to their existence in penury? Do we send our public health teams back to the corners of our health state secretariats where nobody sees them? How are we going to build for the future? And really, that is the challenge for all of us collectively, because we will be held to account. And when in 5 years' time, people will ask, the resources that came into your area, what did you do with it? How did you prepare for the future, for the next outbreak? How did you invest in health security, in scientific, in building up your science capabilities, in pulling in the right people that can do this type of work into your organization? How did you elevate your state epi teams and provide them the resources with it to work? So really, the challenge, Olumide, and I'll stop here for now, is leveraging the resources that are coming into health security now, preparedness and prevention into the future.
Thank you so much, Dr. Chikwe. That was such a passionate opener. In fact, I found it hard to stop you. Normally, I would have stopped my panelists after about 4 minutes or so, but it was difficult doing that. One thing I must say up front, without trying to summarize what you have said, is that health security is an investment, not an expenditure. Because if we had invested in health security at about now, we probably would not be doing as much lockdowns as we are doing right now. And furthermore, public health emergency is part of the universal health coverage financing agenda. It is not separate. They're all part of the different sides of the same coin. And lastly, I like the 3 S's: stable, substantial, sustainable funding. So you mentioned COVID because financing for health security is not just public financing. Whilst public financing is what will get you across the line, private financing needs to be part of the discussion as well. And like you truly mentioned, COVID, under the leadership of Zuera Yusufu, has led out from the front, right globally. And I'm sure at some time we would have to tell the story of how Nigeria private sector came together to provide this support. So Zuera, what really should Nigeria be doing to get the kind of support we saw from COVID on a sustainable basis, so that it's not just when we have a crisis that the private sector comes in with its financing? What are those elements you would like to see in place going forward, Zuera?
Thank you so much, Olumide. This has been, and good afternoon, everybody. That's like the $1 million question. Dr. Chikwe and I have had many back and forths for the past few years about how we should be supporting, the work that he's doing at NCDC, and how do we invest in surveillance? How do we make sure that we have what we need before the crisis happens? And, I'll say it's always been a challenge, very difficult to mobilize when there's not an obvious emergency. So this is a fact. And I'll never forget our first conversation after the COVID-19 crisis. Chikwe said to me, I've been telling you for years, this is what you need to do, Zuera, and now you're asking me what we should do. And I had to laugh because he was correct. We've been talking about, setting up surveillance. How do we do better epidemiology? How do we do what we need to do, et cetera, et cetera? And that never, came together. But when the crisis was there, and when we were in front of the need, then disbursing the money, getting the, organized private sector, together seemed like a much easier proposition. So I think we're not going to keep waiting until there's an emergency, obviously, to do something. But the reality is the private sector now is sensitized in a way that it never was before around what we really need to do. I think even Ebola didn't have the impact that this has had, because remember, Ebola was only us, right? It was only affecting us in Africa. It wasn't disrupting global supply chains. It wasn't disrupting global business, which the private sector in Nigeria is part of the global supply chain. And so the feeling of doom that is connected to COVID-19 wasn't felt when we had Lassa fever, say, or the Ebola crisis. But even if we remember what happened with the Ebola crisis, the first people who jumped up with money to set up an EOC and to provide immediate support were private organizations like the Dangote Foundation. This was before I even came. So I think that what needs to happen is, now that we have this raised consciousness, more awareness about what we need to do, about how much we can actually raise, about how effective the private sector can really be, about how needed we really are as a private sector. I think this is the opportunity for the health sector. And who I'm calling the health sector is agencies such as NCDC and the Ministry of Health and all these other agencies that are working in the health space to really articulate a plan. How do we do it in a sustained way so that the private sector can have an impact? Right now, and this is the last thing I'm going to say before we move on, we've been talking about the Basic Healthcare Provision Fund, right? We've been talking about it for a couple of years. It was launched, et cetera. We've been trying to figure out, how do we get the private sector to actually invest in the Basic Healthcare Provision Fund? How do we get our normal Nigerian private sector to have some kind of funding mechanism to support what goes on in the Basic Healthcare Provision Fund? And we find now very willing ears to say, okay, well, let's really look at a mechanism. Okay, how would it be? How much money is it that we actually really need? How would it be spent? How do we really deploy it? How do we make sure that we use our ability to come together quickly and to put things in place quickly? How do we do that so that access to basic primary health care is actually available to Nigerians? Thank you. And Dr. Chikwe, thank you very much for calling us the most innovative mechanism anywhere in the world ever. I've written that down as a quote that I will share with my COVID leadership. Thank you for that shout out.
Zora, really what COVID has done is innovative. It's something that's going to be written when all of this settles. And again, very well done for the way COVID has risen to the challenge within a short space of time. Just to mention that Zora doubles as the CEO of Dangote Foundation and also the leader for the COVID response. So now, one of the things Dr. Chikwe repeats time over and over again is the role states are playing in the response. There's no federal government that is a state. It is the 36 states plus the FCT. They are the ones on the front lines. And really, this discussion will revolve around the states. So what better place to start than Dr. Abdul Wahab, who leads the health team at the Nigerian Governors Forum Secretariat, almost coordinating what the states do. And I want to hear from you first, Dr. Abdul Wahab, in terms of what's the kind of technical support that is available at the NGF to ensure that states are able to do the right thing, that's on one hand, and two, in terms of advocating for governors for providing the financial resources they need to put in place to fight pandemics like this. It is not when the pandemic hits that we now throw money at it. It needs to begin well before that. So maybe you start from that first before we then go to the technical support that you are provided. Dr. Abdul Wahab.
Okay, thank you, Dr. Olumide, and thank you for inviting me to this discussion. Yes, you've asked a very important question in terms of what kind of support does the states provide, the NGF provides to the states in terms of ensuring that this response to this COVID is effective. So first and foremost, I think what the state tries to do is to come together and so that they can be able to share experience in terms of best practices, so they have the platform. So there's the Nigerian Governors Forum platform, and the state meets since the beginning of this epidemic. The state now has met 14 times, and the reason why they are meeting is actually to strategize together, share experience, and that's what they have been doing. Before the advent of this epidemic, one big challenge that the state has been facing is in terms of actually getting resources that they're going to support the state to actually fight this epidemic. And what the state did was even before the epidemic, the states have been exploring different options in terms of getting resources for the state. For instance, collectively, I think after 2016, you'll find out that the 36 states, collectively, the IGR for those states is about 812 billion. But due to some innovations that the states have been able to do with support from the Secretariat, they have been able to show up their IGR to about 1.3 trillion. But that is still not enough in terms of what they needed to be able to support states in terms of what they require for them to be able to fight this epidemic. So technical support, you asked about what are the technical supports that the states provide. So what we do at the Secretariat is actually to harness some of the good practices that we've been able to see across some of the states and try to translate that in each of those 36 states. That's essentially what we do. So at the Secretariat, we provide this support to states and ensure that the resources that the states are supposed to get, we actually leverage and interface between those, whether we have what they call the other partners or even the federal government, we interface between the Secretariat and the state so that we ensure that all what is necessary, they actually receive that. Thank you.
Thank you so much, Dr. Hamad. You did spend all your time, so that's very good, and it gives room for a lot more discussion. But I have quite a number of questions for you, so we'll still come back to you. But just now to go to Dr. Betta Edu, who wears two hats on this panel. First, she's the chairperson for all state commissioners of health in Nigeria in an own capacity, and also the Commissioner of Health for Cross River State. So, Dr. Betta, the NCDC has said, look, states are responsible for managing the pandemic, and quite rightly so. So, first question to you is, are states capable of leading on the response at the state? Do they really have the resources? We're not talking financial now, but then the second part of it is, do you really have the financial resources you need? So first is, what's the priority that states are giving to this response? Perhaps before now, and then now that the pandemic has hit. Dr. Betta.
Okay, thank you very much for having me. And I want to say thank you to, of course, the organizers and other colleagues for being on this very important webinar today. First and foremost, it would be very clear at this point that a lot of capacity needed to be built for people at the state level, and a lot of support needs to be given to states, both technical and financial. states are able to respond at different levels to the pandemic based on the resources at their disposal. And this pandemic has in fact opened a new window of opportunity, or a very big window of opportunity for states across board to see how they can improve on their public health response, and also attract as much support from the federal government, private sectors, partners, and indeed everyone to see that they respond appropriately to the pandemic. Well, the picture we have in Nigeria is one of having different states being at different levels of response. And of course, this is due to either the human resources which they have in the states being adequate or inadequate, or very inadequate. Of course, you have to consider the capacity of the human resources available to various states, and then the resources, the financial resources in those states. And beyond this, or at the center of all of this, I want to say is the political will of the governments at the state and the local government level to be able to support the response. Of course, even at the federal level to be able to support the response. A lot of fundings are available to stay, or are out there, but very little have been available to states up until now. It's taken quite a long time for states to directly get support from the federal government. We must very strongly commend the private sector for stepping up really hard into the shoes to see how they can support states. COPREP has done an excellent job. My state is one of the beneficiaries of the work of COPREP during this pandemic, and we're very happy for that. We are also happy that finally, at least, there's that push to start the Basic Healthcare Provision Fund, which would make funding available to states, although like the DG of NCDC has rightly said, they should be that consideration for public health emergencies in the Basic Healthcare Provision Fund. Unfortunately, funds like Save 1 Million Lives that would have also been plowed into the response, the COVID-19 response, have not really had that kind of support from the federal level. So far, we're still awaiting the results of the last Smart Survey to be released, and then funding made available for states to cope with. We're happy to hear about the COPREP, which is coming up from the World Bank in collaboration with NCDC. We believe that is going to help states to improve. And then, of course, we're looking at a situation where all states can quickly start their state health insurance scheme, which will further help to increase the post that's available to them. The REDISSE was one very important support that have gone to most states. We're happy that about 29 states thus far have received the 100 million available through the World Bank and NCDC. However, we still have states that have not received, and like this is just a tip of what is really required across states. I'm sure if you have listened very carefully, you will know that some states had to go as far as getting funding from the local government purse to improve on their response. And NGF, the Secretariat, has done an excellent job in trying to beef up the political will of governors and even other stakeholders to help the states to respond to this. What is important is the fact that the health sector, we believe at the end of all of this, will never be the same. This window of opportunity will be properly used to improve on a system, a resilient health system that can be able to stand whatever pandemic or epidemic or outbreak that might happen going forward. We want to also very strongly believe that from the federal level, as soon as possible, we'll begin to see these fundings made available to states. Remember, the cases are really at the state level. That's where the management is. It's really very difficult and stretching on so many states, and you find states adopting systems like saying we would have home isolation or home treatment for some patients just because they are unable to carry the heavy burden of case management in the various isolation centers. You also find states saying that running the labs are really very, very expensive for those states. Running EOCs are expensive for those states. But we believe with continuous support from the federal government, from the state government, the right political will, and indeed support from even the local government and health workers across board, we would be able to pull through the pandemic as soon as possible. Thank you.
Thank you so much, Dr. Betta. You really covered the field. So I'll now move to your colleague, Dr. Yakolade, the Commissioner of Health, Ekiti State. And she's on this panel for a specific reason. First, Ekiti State was the first state to draw down on the 100 million naira from REDISSE through the NCDC. So just to summarize what Dr. Ajiboye presented earlier on, so states will get 100 million naira through the NCDC from REDISSE port, and with the newly approved COPREP project, states are going to get, even by my own calculation, depending on the foreign exchange rates we are using, close to $1 billion naira. This is a lot of money. So my question directly to Commissioner of Health, Ekiti State, Ma,
yes.
What do you want to use these monies for?
Thank you very much. My first response is to appreciate you for inviting me into this group of excellent panelists. And I see a lot of friends that I haven't seen for a while. Zuera is there. I'm seeing Dr. Chike. So beautiful. Let me start by what we went through in Ekiti State and what we did before we got to this point. If you remember very well, on March 18, we had our first case. When the first case came on board, it was unexpected. We were thinking most cases would start in Lagos, Abuja, and we are interland. And right away, we started financing from the state pocket. And what did we do? We started establishing our isolation center. I'm going to run quickly to let you know what we have done and what we are planning to do. When we did that, we started with our isolation center. The fund was not enough, definitely, but with the meager funds we have, we started doing something. His Excellency, Dr. John Kayode Fayemi, started something in Ekiti. What we call the Resource Response Mobilization Committee was set up. And this committee is a blessing to us because these are the people that actually helped us in getting our first molecular lab, which we had none in Ekiti State. And from our state, we had to go to Ede, or you go to Irua, which is quite some distance. And without testing, we cannot even treat anybody, we can't diagnose anything. The other help that we got majorly were from the private organization, which were, the MTN, the COVID, the Dangote Group, and all the victim support. They gave us money. Ekiti State had no isolation center before this pandemic. Let me stress that again. Not a single bed designed for isolation. Yes, I'm sure Ekiti State is not the only state in that predicament. So we had to quickly start from the scratch. Thank God for the innovative ideas and the creativity of our governor. And working with the team, we found a location, we started with beds, get some ventilator, mattresses, all the 9 yards of everything that we needed. That being said, we are well plugged into the REDISSE fund, which we thank God for. What we are using those funds for, we are educating, we are increasing capacity building for our workers, we are providing support for our frontliners, we are strengthening our laboratory pillar head, the IPC pillar head, surveillance team, risk communication. All these pillar heads are being supported. Before the REDISSE funds, we have done some training, but have we done enough? No, we were far from doing enough. We needed to train more people. We had only 10 laboratory specialists and 5 of them were engaged. Definitely we can't test enough. So now that we have the capability of training at least 64, I think if I'm right on the number that the REDISSE fund has allowed, that means we are going to have our laboratory scientists are going to be trained. We're going to have our data collectors going to be trained. We're going to train our World Health facility workers are going to be trained, including our OICs, MOH, health educators. We are actually going to the grassroots and training. It's good to train. We still have infrastructure to build. What are the things we need? We really need a standardized isolation center. To really have a standardized isolation center, you need an isolation center that has negative pressure. Negative pressure isolation center is where you will have your air coming into that center being filtered and would not be dispersing infection to your community. We needed another lab because we are having a backlog of samples. These are a lot of things that needs to be done. If not for NCDC that gives us one helix for surveillance team, we had no helixes, we had donated ambulances. Before this pandemic, there are few working ambulances in Ekiti State. So this has created a lot of, you could see the major gap that we have. And this gap has to be filled. I'm very grateful to God for one thing. This has brought everybody to the same level. We now realize you can't run to America, not London, or England, or UK, or anything. And thank God for the great hands that have provided all this thing. This money is needed. The healthcare in Nigeria is in shambles. Let me use a strong word. We're not where we should be at all. We shouldn't be in a state that we cannot point to a real infectious disease hospital. We shouldn't be in a country where there are very few ventilators. People are dying because of lack of oxygen therapy. People are dying because of a lot human resources. The numbers of doctors at hand, how many of them are specially trained? How many consultants do we have? How many infectious disease specialists do we have? How many pulmonologists do we have? Do we even have the knowledge, the knowledge know-how to carry out all these things? These are basic things that should have been within the system. You know, it's rather late, but I mean, it's better to be late than never. That's what I'm trying to say. The state where Nigeria is, I believe, if we actually strategically plan, and we will be able to execute, and things will be better in the healthcare system. This money is absolutely needed for the people. If we truly care about our citizens and we truly care for a better Nigeria, this is the time to make a change. I'm not saying America was in a better
Thank you
place.
very much. No. I think you've made you've really articulated the things that those resources will be spent upon, all the way from training, for human resources for health, acquisition of commodities and consumables. I was also impressed the fact that you highlighted the fact that even before federal grants started coming in, you have already, you were proactive to use your own state resources to put in place necessary infrastructure. But we will still come back to the issue of transparency and accountability in terms of how you spend your own funds and the grants you receive from the federal government. I move quickly to ACIOE. And I will start from a broader level. ACIOE, is Nigeria spending enough on health? You know, because that to me is really the first question we need to ask, so that it's not just a matter of firefighting all the time. And if we are not, what do we need to do? And what's also the role of state governments and local governments in financing health? Otherwise, if we continue to do what we're doing before, then nothing would have changed indeed.
Olumide, please, can you take the question again? I think there was a bit of network challenge. Is
Nigeria spending enough on health before COVID? You know, and what really is the responsibility of states and local governments in financing health?
All right, thank you, Olumide. I think the simple response is that Nigeria isn't spending enough on health by a number of indicators, right? If you look at the per capita spend, the government spends about $10 per capita on health. Most of the expenditure on health is actually financed out of pocket. If you look at how much the government spends as a proportion of the GDP, it's extremely low. In fact, one of the lowest in the world, especially when you then combine it with the fact that we are a lower middle income country. It's just about 0.5 from 2017 data. Yes, about 0.5% of GDP being spent on health. If you also look at the how much of money is budgeted to health, generally it's it's around 5% of the total budget that's spent on health. But again, you see the argument from another side, which is, is Nigeria government also raising enough revenue? And the response, the short response to that is also no. In terms of tax mobilization, we have one of the lowest in the world. The government is only able to mobilize less than 10% of the GDP. For you to make any substantial dent, you need to do about 20% of it. So the short answer is no, we're not raising enough. We're not spending enough on health. What do we need to do? There are a number of things we can do when you look at the ways to mobilize more resources. The first, I think, is mobilizing more general revenue, and that largely would have to do with tax reforms to be able to mobilize more money. Unfortunately, given the crash in oil prices, it's likely we're going towards a recession. So again, there's also the public appeal of this. You're going to increase more taxes, or perhaps even increase the tax base. So we need to do some tax reforms to be able to mobilize a lot more resources.
Do you have any recommendations? Do you have any recommendations in terms of sustainably funding for health security over the years? Because yes, there's that challenge, the chicken and egg challenge. Oh yeah, we're not raising enough revenue. But now we have even lost more because of the lockdowns. So addressing the DG NCDC's perspective of stable, sustainable, and substantial funding for health security, how do we do that balancing act? What are your thoughts?
Thanks. Yeah, so I think it's still along those lines. I get what you mean from the chicken and egg situation in terms of raising more general revenue, but what countries have also done is to also earmark revenues. So for instance, the Basic Healthcare Provision Fund is an earmark financing, right? Unfortunately, like the DG of the NCDC said, I think more recent reforms on this actually remove that additional 2.5% of the total BHCPF fund that would have gone to public health response generally. So that would have been a very good opportunity, right, to do that. The issue about innovative tax revenue, airline taxes, sin taxes, and all of that, while they appear good, but there are also issues around how much resources this can potentially really generate. The other issues around development assistance, it's not very sustainable. Like you can see right now, yes, we're having to live with a lot of it, but as Nigeria grows economically, we've moved from lower income group to middle lower income group, right? So there's something called transition financing transition. So essentially, development partners will find less because we're developing, so to say. So again, that has its limitation. For instance, you can see Gavi having to renegotiate its financing with Nigeria and the period over which this financing will be available. So this is an ongoing discussion, but I think the BHCPF will be a missed opportunity if we don't capitalize.
Okay. A very good point and very well made too. This has been, questions have been coming in really in droves. Before I go to Dr. Chikwe, let me just have a 30-second response from Dr. Betta Edu. Just a 30-second response from you. Where is your state epidemiologist sitting in the secretariat? Is he sitting in a dingy, he or she sitting in a dingy office? Or he's really now part of the management? Just a 30-second response, just on a lighter note. And I will ask Dr. Mojiaya to also answer the same thing. Where is your epidemiologist sitting?
So my state epidemiologist has a full office dedicated to her. And of course, we are one of the states that had an EOC that was commissioned by Dr. Chikwe, and we have support from the USAID for the EOC. So we have a full, well-established EOC with the state epidemiologist. Yeah.
Dr. Yaya Kolade.
Yes, thank you very much, Dr. Kola. Basically, my state epidemiologist has a full-fledged office. We have a full-fledged EOC center that we put on. It started, I think, December last year, but January, we just finished it just before the pandemic started, and it was inaugurated. So we have a full-fledged EOC in Ekiti State.
Okay. Thank you very much. I wasn't being flippant. I just wanted to demonstrate, and for you both to demonstrate on this call, the kind of prioritization you are now putting on for health preparedness and for health security. Because going forward, a new normal is one where health security now becomes priority. I go back to Dr. Chikwe. We're talking about financing here. If you were to advise states, you cannot advise 37 states all at once. But where would you want them to spend all of these monies that we're talking about? Where should they place emphasis based on the data that you are seeing today?
So thanks, Olumide. I don't think it was fair for you to put the Honorable Commissioners on the spot. There's actually a link to your next question.
That's okay.
There's a link to your next question. You know, people think that spending money efficiently is easy. Spending money efficiently is very hard. So, you know, states are going to get considerable resources. The state epidemiologists, as well as the Honorable Commissioner, are the primary recipients of the first 100 million, and they will be responsible for the next batch of funds coming. There will be other resources coming in from different areas. If the teams around which we used to have one state epi, sometimes an assistant, sometimes a state DSNO, and sometimes an assistant. So in many states, the total health security architecture in a team in a state was 4. That whole concept has to change. You know, we have to build around, and I'm generalizing that we have to build around these teams to enable them grow and take on that responsibility. The DG of WHO says that primary healthcare and health security are 2 sides of the same coin. In Nigeria, they are not. You know, health security is kind of the small little brother after primary healthcare, health insurance, everything else, hospital services. And sometime at the end of the discussion, somebody will remember public health. And it's not unique to our states. This is how we're socialized. Those that went to medical school in Nigeria will remember how community health was dealt with. You know, you finish your surgery, obs and gynae, and everything else, and maybe somehow somebody ends up in public health. And so this is different. There's nothing else in the world that has stopped a global economy for 3 months. In my lifetime, nothing has led to a national lockdown in Nigeria. Nothing. So this is a new normal. And if we don't, this is a new normal, but it is a moment. It is a moment for health security. And we have to seize that moment. So if I were, going back to your question, if I were a state commissioner for health right now, managing World Bank funds is very hard. They will not tell you. They will not tell you, but it is hard. You have to account for every expense. You have to be very careful that you deliver. You have to show accountability both in the deliverable and in the financial resources. I will start building the people around it so that you can absorb the funds and use it and improve your own capacities. And these are not just technical deliveries. I'll bring in the finance person, project managers, people that document, process, and all of that to build a team that can absorb these resources, deliver on its use, and use it to serve the purpose of strengthening their health security in the states. And at NCDC, we are building a team to support the states, but we can't go to any state and implement. All we can do is, listen, support you, provide you guidance, training, come there, but ultimately, the states have to deliver. And to build that delivery mechanism, a delivery unit within your state MP architecture is what I'll be focused on, because once the money comes, you've got to start spending. And I know from my own NCDC, the World Bank is always harassing you, why haven't you spent? I said, listen, spending is not easy if you have to go through these very rigorous processes all the time to spend efficiently. And it's a good lesson we have learned and we continue to learn how to spend efficiently because you're forced to do so by the processes in place. Over.
Thank you so much, Dr. Chikwe. Again, I'll move to Zuera because we're already getting questions on maybe if we raise our revenue through increasing taxes, through innovative tax financing, we'll be able to raise more revenue. And I think there's a strong, rather than going to lockdowns where you will not be even, where the private sector will not be able to make money at all. So as we get all of these ideas, because there are about 3 questions now or 3 suggestions in terms of expanding the tax base and also raising the tax rates. So Zuera, how much capacity does the private sector have now to contribute a whole lot more to the port? You know, I want to assume that the same transparency and accountability mechanisms that the DG has mentioned also applies to funding from the private sector. But really in terms of how much more are you ready to give? What's the private sector saying about that?
So that's a really good question, Olumide. The biggest challenge, obviously, is that the private sector has felt the impact of the lockdown in a very significant way. So if you think about, you know, if you just think about, for instance, take a bank, right? A commercial bank that has exposure to the oil industry, to SMEs, to hair salons, to all kinds of businesses, to airlines that haven't been in business for months. Imagine what it means for their bottom line. Look at how many NPLs they're going to end up with in their books. How many people have not been able to service their various lines of credit, loans, etc., simply because the customers haven't been there. So the repercussion on the private sector is immediate and gigantic, right? So the people who are struggling right now are people in the private sector. You can't keep paying employees to show up when there's no customer. How do you then generate enough revenue that would even be taxed by the government? So the ability of the private sector to contribute to the fight is dwindling by the day, as long as we keep staying in this shut down economy. We're reducing the private sector's capacity to contribute money, right? So this is just basic math. So the private sector stands ready. It's not like, you know, people aren't, depending on what kind of company we're talking about, the ones that have been able to contribute to COVID have, you know, mercifully been the ones that have bigger balance sheets, will have bigger capacity to withstand some of these shocks. But the reality is that their ability to have more money available for them that they cannot even give away is reducing the longer we stay in this lockdown phase. So the lockdown is difficult for it's difficult for everybody, but imagine private sector gets money when the economy is open. So the longer we keep the economy closed, the harder it's going to be to get the private sector to contribute more and more and more funds from money that they are getting less and less and less of. So right now, you know, CACOVID is committed to, had committed to 3 really specific things. 1, increasing testing. 2, providing isolation center capacity across the country to all 36 states plus FCT. And then 3, which is the phase that we're in now, providing palliatives to 10 million people. So if you just see that the palliatives themselves, just getting food, a basic food basket that costs about 13,000 Naira, getting that to 10 million people, 1.7 million families, is costing us 23 billion Naira. Most of the money that CACOVID has spent has been on money, but on food. But the scary, almost, the thing that keeps me awake at night is how much longer are we going to be in this situation where the economy is closed, the airports are closed, things are shut down, people are working half time. Like, how are we really going to be able to manage this? How long are we going to be able to hold on? So there's going to be a balance where the economy opens up, private sector goes back to work, money is flowing again, and the private sector can contribute even more to this kind of an effort. But it's definitely a difficult challenge, and it's becoming more difficult as we last in the lockdown, I would say. Over.
Thank you so much. Thank you so much, Zuera. It's never an easy question. Lives or livelihoods. Which one do you want? And at least nice to know that the private sector continues to support the pandemic. But I think this is, from what I'm hearing and reading, it seems we still have to stretch the private sector a bit more to raise some revenues from them. But I go back to Dr. Hamad. Look, one of the things Ayo mentioned is that states are not prioritizing enough financing for healthcare. And that's probably why we're where we are today, that everybody is scampering. Yes, you know, all of the monies that we had in the presentation, yes, they're coming from the World Bank and all of that, but how much are states actually allocating to health? Is there a mechanism, like a peer review mechanism, where governors are able to hold each other accountable for how much they are able to allocate to health in their budgets and actually release? You know, I really would like you to address this.
Okay, thank you, Olumide. I think for the governors, health is actually a priority. We know there's the Abuja Declaration that actually encourages states to allocate 15% of their budget to health. We've had, I think, at the Secretariat, this is one of the indices that the health team, the Secretariat, is actually tracking. At every meeting of the Governors Forum, so we have a scorecard whereby we try to track progress in each of the states in terms of what is it that they are allocated. That's not the only metric we track, but there are other metrics too that we track at each of their meetings. But I really want to tell you, yes, I think there are lots of priorities for the governors. It's not easy being a governor because everybody will come to a governor and then he will come with his problem, each of the sectors, and everyone will try to say, okay, this is how important the sector is. And as such, you need to allocate funding. But I think the this COVID epidemic now has actually trying to actually emphasize the need to actually put more funding to the health sector. And we have a couple of states that have actually achieved that 15%, 1 or 2 states. And the other states are also trying to see how best to strive to actually achieve that 15%. But I think one thing is not just about that 15%. I think it is even how you're able to efficiently allocate funds to areas where it is needed most. And that is one thing that I think the Secretariat is also encouraging states, trying to advocate to states to ensure that even the little resources that you have, you are able to allocate it more efficiently. And that is one thing that a couple of the states now trying to ensure that funding goes to the health sector. One thing again that the Secretariat is actually doing to ensure that health gets more funding, there is this concept of tax for service that the Secretariat is trying to put, that we're trying to use tax as an, we want to use health as an incentive for states to be, for the informal sector to be able to actually contribute more funds into a pool. And we're going to use, and that fund, because it is health that is being used as an incentive to actually encourage them to pay tax, that funding is going to be allocated to the health sector. So apart from that, even the state health insurance now that you now have states now trying to ensure that each of the states sets up a state health insurance scheme. You now have most of the states now have now established the state health insurance scheme, but you know there are a different level of functionality. About almost 14 or 16 states now actually have started enrolling beneficiaries to start accessing care. So when you put all those things into perspective, you say, okay, these are some of the priorities, these are some of the interventions that states are actually doing to ensure that funding goes more to the health sector. But at least we cannot just take health out. We have to look at the whole situation, the whole challenge in the fiscal space, the dwindling of revenue and all those stuff. But okay. I think just to summarize, to say that you have different options, different interventions that the states are doing to ensure that more funds gets to the health sector. And the coming of this COVID actually is trying to actually help to actually ensure that states allocate more funding to the health sector. Thank you.
Just let me move to Commissioner Ekiti State, Dr. Yaya Kolade. I'm just reading one of the comments from the chat box that, look, it's very easy to prioritize having a molecular laboratory, increasing testing capacity, building isolation centers. And we seem to forget the basic things that work, things around contact tracing, things around behavioral change communication. So Dr. Yaya Kolade, how much of this is emphasized in your IAPs? Right now, and even prior before today. Several states have crews that are not employed. Just a very quick comment on that.
Thank you very much. In Ekiti State, as we are concerned, risk communication takes a big chunk of what we're doing. And we started that even before we had our first case. So now with the prioritized IAP that is being supported by REDISSE, it's still carrying a big chunk because we know proper education of the public is very, very important. Prevention is a big part of what is going on. Eliciting the signs and symptoms of what COVID-19 looks like is very important. Educating the public about how to respond and what to do, where to call, whether you call it 112, and the response numbers that we have, those are very important. Another thing that is very important that I saw is that we did not even neglect the other non-communicable diseases that are available, that are around us already. So malaria is not neglected, neither is diarrhea, neither is immunization. All these things that's been in place. I think we are one of the very first states that has the task force inaugurated before any other person. So that means we were ahead of things in planning in what we need to do. We are not just reactive. We were responding before even the event happens. One thing that is important is that there's no pillar head or any aspect of the emergency operations system, response system, that you can actually neglect. We are working with the research pillar head. We're actually doing surveillance testing in Ekiti State. We are not just doing random testing. So everything has to be coordinated. It has to be in collaboration. And one thing I just want to add, which is not one of your questions, is that effective judicial spending in health in Nigeria will make things better for everybody. Because when people plan, effectively plan, strategically plan, you'll be able to execute. And there must be a good mechanism for management and evaluation to assess what you have done. Accountability is a big part of what we are doing. And everybody must be accountable.
Dr. Moji, I'll stay with you one more minute or 1.5 minutes. Can you just tell me, because we heard from Dr. Chikwe now, who said, yes, look, it's not easy to spend World Bank money. Tell me, what are those key issues around transparency and accountability, not necessarily for World Bank funds, but even for your own state funds, that ensures that monies are spent judiciously, which you are alluding to? Can you just give us a few flavor?
Thank you very much, Dr. Lumine. When I came on board, which is about 15 months ago, I'm very lucky I had a good teams on ground. And any place that we notice that this is not going to work, people were changed around. And this makes things, we work as a team. We sit down, we decide, there's no secrecy in what is being done. And when we are talking as of today, when we buy from the best source, we use the best source, we go through the market, who is going to give us the best for the money? So it's not just buying, give me the best for the money that I'm putting in there. And this is done by a team. And if we see that anybody is trying to do anything unscrupulous, we will not allow that, because my name matters to me as a person. And the name of the state matters too. And it depends on the people you are working with. So in my own opinion, let's take REDISSE for example now. Yesterday we were at the EOC, we discussed what it's meant for. Every pillar head was being given, I as the coordinator of the EOC, I was there, the IM was there. We are giving directives. This is what you need to do in your own pillar head. Go and give us a breakdown. How does this money get to the grassroots? These are the people that should be involved. The IMOH, the IOC, the health educator, the this, the that, and even up to the town announcers. They don't like to be called town criers again. And those are the things you need to go to the bottom of what you need to do. The nitty-gritty, the intricate things has to be well stated. And once that is done, I think it makes it easy to follow up on what needs to be done and whether it's being done. It's not just saying, go and do it. Go out there to supervise and see, is it being done? Supervision is very important.
Thank you, Commissioner. Because DG NCDC has put the World Bank on the spot. It says, hey, look, and I'm quoting Dr. Chikwe here. World Bank money is not easy to spend. Dr. Ajiboye, all Nigeria states in the last few days or so have received or about to receive 100 million naira. In the next couple of weeks, they will be receiving close to 1 billion. There's also a lot more money they will be receiving through the PTF, amongst other things. So can you just summarize for us? Yes.
If I can add one thing, let me give you an example.
Oh, let me come back to you. I will come back to you. I'll come back to you. Dr. Ajiboye, just summarize for us. What are those things that ensures that monies are adequately spent? Maybe in about a minute or two. Just top headline that makes transparency and accountability on World Bank funding so difficult, supposedly.
Thank you, Olumide. I think I wouldn't agree that it's very difficult to spend World Bank money. I think really what and I don't think you want to quote Dr. Chikwe out of context. I think what Dr. Chikwe is alluding to is that it comes with quite a lot of accountability, which ideally should be with every source of funding, including public financing, right? I think maybe just to mention specifically on the COPREP / REDISSE, because they're basically adopting the same kind of mechanism. Really, for the COPREP, what the states would have is really an impressed account. So the accountable officer or the accountable institution is NCDC. So if you understand the way impressed accounts operates, is you're spending on behalf of NCDC. So there's going to be an MOU in place. In the MOU, you have to first detail your activities that will be funded, and that would go through a lot of technical rigor to agree to the fund, and then also agree on regular reporting. The funds will be provided to you in tranches. So if you get a first tranche, for instance, this REDISSE, you need to account fully for it. It's very different from SOML, where we use another instrument called the Program for Results. I also know a lot about that. In this case, it's an IPF, investment policy financing. So you need to account for every cover of bank funds that you use. So periodic reports will be offered, both financial and programmatic reports submitted to NCDC before you can get subsequent tranches of fund. If you do not, if states do not fully account for this, one, further funding will be stopped. Secondly, is also that they may be asked to return the money. It will be classified as ineligible expenditure. Some states under World Bank have expressed. We hope we don't have to do that. We're also using a lot of development partner support. We're leveraging a laboratory on that. Our development partner at the state level will work collaboratively with states to ensure that what they submit, passes the technical rigor. They help in the monitoring and evaluation and all of that. NCDC, like Dr. Chikwe admitted, would also be deploying staff to also help monitor what's going on at the state level to ensure that funds are properly spent. And there's also the option to use a third-party monitor that will go across states and ensure that money are spent. Above all, we would promote a lot of transparency in terms of publishing online. these reports that have been submitted. This would enable, the public and CSOs also to have access to this, and they have every right, like in all World Bank projects, to ask questions. Oh, you said you bought this. There's no evidence of this. So they would also be heavily involved in all of this. So I think those are some of the
yes. Thank you, Ayo, for emphasizing that this is not a slush fund, be it World Bank money, be it private sector money, be it public funds. And I know Dr. Chikwe, in all his interventions on this panel, has emphasized the role of transparency and accountability. We're going to spend the last 15 or so minutes on this call just to emphasize the issue of transparency and accountability, which is something that has been in the media of late. And I will ask to let people on this call just have an idea of the kind of mechanisms, fiduciary mechanisms, that are available within the LCDC. That's one. And the second one is a question from the chat box, which is saying, look, when we are advocating for funds for health security, are we not sorry, Dr. Chikwe, thanks.
So, Olumide, thanks again. None of these mechanisms are new to any of us. It's just that we have to implement them in detail all the time. And this is something that may not always be the norm. So, but once there's apart from the World Bank, I know I've said, it's not hard to spend World Bank funds, but it's also not hard it's hard to spend FGN funds. And, you can see all the sometimes quotes in the pages of the newspapers. Once you're given extra funds, and there's an added level of responsibility, and it's been clear to us in the beginning. There's no management meeting we have at NCDC. We don't say, listen, this funds coming to us is public knowledge. We have to do everything to the book and do it diligently. And that is really at the heart of this. But the financial part is only one part of this, which is one thing I want to stress. The issue is, are we using the funds to deliver on what needs to be delivered? And sometimes these are not easy choices. So are we just buying things because it's easy to buy and account for? Or are we making strategic decisions for investments in areas that are a little bit more complex to deliver, but is the right thing to do? So, for instance, if you're buying PPEs, it's very simple. You buy the PPE, you deliver it, and case closed. In most cases, the accounting process is very straightforward. Now, to establish a supply chain to deliver reagents from a state to a lab locally, or whatever you decide, where you're building a system of delivery, it's a little bit more complex, because you now have different components of human resources, transportation, and all of that to account for. So sometimes it's a disincentive for those types of investment, but those are the investments that will make us safer. So I don't want us to reduce this to a simplistic accounting for funds, because that's just the first. The bigger and more difficult thing is, are we making the most strategically important investment in the health security outcome that we wish for, rather than just spend in areas that is easier to spend because the process is much simpler. And that's really where we will rise or fail as we move forward into the next year.
Sorry, the question on verticalization. Just any thoughts on that?
So the verticalization of anything in health, in public health, is almost is too short-termism, too short-sighted in order to reach our long-term objective. And in a way, the division between health security and primary health care and health insurance and HIV and TB and malaria are all, ways to manage resources that are coming in, but not really ways to deliver most efficiently, because all of these bits are interdependent on each other. for their delivery. So, you know, this continues to be a big area of debate. And, you know, whenever you ask, should we do horizontal versus vertical, everybody says horizontal, but goes on to do vertical programming. And because it is harder to do horizontal-based delivery versus vertical delivery of programs. But that's the challenge for our generation in terms of how to pull these resources together to deliver the best outcome for our people.
Just staying with you, Dr. Chikwe, you know, just very rapidly. Number one, could public-private partnerships be an option? You spoke about supply chain. Could there be a possibility where you aggregate consumables and then leave that to the private sector to help you with the delivery to the end users? Could that be something that you might want to explore in this response? Whilst you take that, I also have another question from the chat box that says, look, a lot of people believe that COVID-19 is not real, that there's a lot of cynicism. What message do you have? You know, thank you.
Okay, so the first question, you know, it sounds easy, and many people have thrown this to us. You know, you guys are delivering PPEs. Why don't you bring in Coca-Cola or one of the big companies that deliver across the country to carry your stuff? You know, for the type of work we do is a little bit more complex. I'm not saying it's not possible, but it really needs patience from the private sector guys to understand the unique circumstances around safety, care, precaution, and things like that in delivering medical items. And it also needs a specific type of people that can work with the private sector to deliver. So I think if pushed, we can do this. But if we just allow ourselves to look for the easiest solution, we won't get to this. So it requires some extra stick and carrot to bring components of these two sectors together. So on your final question on people thinking that this virus is not real, you know, I really never know where to start with this. And I always start by saying, in the position of responsibility and privilege that I happen to be in at the moment, you know, I've been exposed to many colleagues and friends that have either been extremely ill from this virus. Some of them have actually lost their lives. And, you know, so I think it's almost disrespectful to them and to people that have gone through so much pain, families, communities, to now think that there's an alternative explanation to this phenomenon that is happening around the world. But it also goes to, at least in Nigeria, something really important in our society that we can actually do something about. I think our science education needs a lot of thought on where it should be. You know, so when I've heard some of the arguments about hydroxychloroquine or whatever Madagascar cure or whatever has come on the, you know, in the national discussion. And, you know, I've seen people that I respect use words like, I believe that this cure works. You know, it goes against the fundamentals of our profession. Medicine is not based on faith or belief. It's based on science. The fact that the measles vaccine works is because there's a way of comparing this vaccine to others. And there's no alternative to defining what works in medicine than what doesn't work. So I think there's a lot more work we have to do. This is really not about COVID. It's not about Ebola or any of this thing. It's really about understanding how science evolves, how we develop our understanding of viruses, and how we develop our understanding of how medicines are developed and vaccines are developed. If we go back to those basics, then we might be able to have a conversation. Without that, it's impossible to have a conversation at the level we are at the moment because the belief systems are too separate from each other to come to a common consensus.
Thank you so much, Dr. Chikwe. It's really a pity that 6 months down the line, several lives dead, you still have some Nigerians who are still skeptical about the mortality that we're experiencing from COVID. This, in fact, is real, and it's a pity that you still have naysayers saying this doesn't exist. Let me bring the attention of everyone on this webinar to a fantastic initiative by the Central Bank of Nigeria. The Central Bank just launched what is called the Health Research, I got it here, the Health Sector Research and Development Intervention Grant Scheme. This is almost the first time Nigeria is experiencing, where the Central Bank of Nigeria is putting down huge pot of money, close to 200 billion, to spur research as a result of the COVID-19 pandemic. Again, this is mostly an initiative of the Bankers Committee, private sector again coming to the rescue. So Zuera, you see the private sector really leading on several of the things that the public sector should be doing. In other parts of the world, it's not the Fed that will put aside money for research grants. So we've overflogged this. But from your perspective, what do you see in terms of potentials for public-private partnerships? How do you view that happening?
Thank you, Olumide. I know that the public-private partnerships have been touted as this panacea, right? We're gonna mix in the private and the public, and we're gonna take the best from the public and the best from the private, get it together and just do it. And it turns out to be a lot harder to do than I think it looks on paper. So we have a lot of really good examples of PPPs that have worked very effectively. From my IFC days to my World Bank days. I mean, in Cameroon, there was a way to, use the private sector to administer public hospitals and clinics, et cetera, and that was really effective. I think for the research agenda, that's the only way we're going to be able to do this. Research is inherently difficult, expensive, long-term, no immediate results. It takes forever to do. And I don't know who said this at the beginning of the webinar, but it's not in the middle of the fire that we're trying to figure out how to build the fire extinguisher. And that's what we need to rethink in terms of what should we invest in terms of getting a return that makes sense. It's very difficult. It's still difficult. It's difficult for me, and I run a foundation focused on health issues, to really find ways to fund research in a significant way. And it's not easy because we have so many competing needs that are immediate. So, the arbitrage that we're trying to make is, should we spend money, because we have finite amounts of money, but what are you gonna prioritize? Is it saving X number of people immediately, or spending that money on a probable maybe we'll find a cure eventually one day in the end further down? So it's always a difficult thing to do, but I think the only way we're ever gonna be able to invest and get our own research, and whether in this particular case we're talking about COVID-19, whether we're talking about tests that are produced here, that are manufactured here, that are done here, or whether we're talking about potential vaccines or any other kind of drug that we need to have on our continent, I think this crisis has made it clear that we need to start doing that, because we realize we have nobody to rely on but ourselves. I remember in the beginning of this pandemic, everybody thought hydroxychloroquine was the solution. India said they're not exporting hydroxychloroquine anymore. Okay, well, who makes it here? Nobody. We don't have hydroxychloroquine. We only have chloroquine, which we haven't even given anybody a license to make in a long time, et cetera, et cetera. So I think this is just a time where having the public sector and the private sector sit down and really have the difficult conversations about what are we really going to support and what are we going to do together, so that we are able to move the needle forward in our quest for better health for our people. But I think it's, like Chikwe said, it's really hard to implement effective PPPs because the incentives are very different. How do we align public companies with, public sector with private companies? How do we get the incentives together? How do we get the funding mechanism together? We're still struggling to figure out how to support basic healthcare provision trust fund. That's like a real life example of something that is taking us, over a year to get a mechanism that will, give us the results that we're looking for. So I think to talk about it is the beginning, to have intense conversations about how do we really do this, and to make sure that everybody is on the same page that this is what we have to do. If we don't do this, there's no answer because there's no solution coming from anywhere. People will help us. I used to work at the World Bank. The World Bank will help us for a minute, but even if we say we're giving 100 million to the states, how much of a solution is that going to be in terms of a long-term thing? This is a project that will solve a temporary problem, but how do we do the things that will give us the longer term results and answers? Olumide, don't laugh. I'm saying the truth. It's good. We want everybody's support. I'm not knocking anybody helping at all, but I'm thinking the real answers are going to come when here in Nigeria, the Nigerian public sector and the Nigerian private sector work together to leverage off of one another and get answers. We can't continuously rely on the goodwill of somebody to help us, and it's never going to be enough anyway. All right. Oh, over, as you say.
Right. Thank you so much, Zara. Thank you so much. Those were very strong points to make, and I do completely concur with you. I go to Dr. Ahmad as we begin to wind down this webinar. Now, you've also told us you meet with all the 36 governors. In fact, in the course of this pandemic, you mentioned you've met well over 10 times. We've attended some of those as well. Just let's assume, I know the chairman, Dr. Fahimi, is someone who is very hands-on. If he asks you, Dr. Ahmad, can you tell us, governors, what's your key takeaway from this webinar to my brother governors? What will be your key message to this august body of governors in terms of we've had a discussion on financing at the state level, probity, accountability, amongst other things, and low financing. What will be your own key message to those 36 governors who hear you all the time?
Thank you, Olumide. That's a tough one that you're asking me for the key messages. But I think for me from this webinar now, I think we're just trying to emphasize the importance of actually providing funding for the health sector. But apart from providing funding to the health sector, what is important is accountability and then efficient use of those resources. I think that is what we are promoting. And again, one thing that I think that I had, which is really very good, is something that has been repeated, to say that we shouldn't just depend on external resources. We also need to put our own funding into the health sector. And I think it is important that when we put this funding, we need to prioritize appropriately. So allocative efficiency is critical. Trying to put money into, we should be able to actually allocate funds to our areas of priorities. And then we should also mention, we should ensure that we spend this money judiciously. So I think those are my takeaways, that we need to put more money into the health sector. And then it's just not putting more money. We need to release those funds. And then we shouldn't just rely on external funds, but we should also put our own money, government money, into it. And then we should ensure that there's accountability in how we spend this money.
Dr. Abdulwahab, you see, after all, that wasn't a trick question. Those were exactly the same things I wanted you to prioritize. Very well done, because that's exactly what our governors, the message our governors really need to have. Because if we've been spending at the level that we should normally be spending, honestly, this would not have caught us out. At the beginning of this pandemic, ladies and gentlemen, we had total less than 300 ventilators across the country. I mean, we had only 4 laboratories, molecular laboratories working. It's a pleasure and delight that we now have about 66 functional molecular laboratories. We've made progress rapidly, but it is not every time we go into firefighting mode. Bami and team, maybe just 1 second, because a lot of people are asking to know more about the CBN grant. If you can just put that back on the screen. Already about the latest figures I have from the CBN is that a lot of this money has been disbursed, but please, if there's something that you can take away from this webinar, is the availability of funding. And this window will close in the next 1 month or so. This is a huge innovative financing approach from the Central Bank of Nigeria, which is saying, look, bring up your ideas. We will fund you. This is what the National Institute of Health does in the US, but we have the CBN doing it. And I think, look, if you don't rely on outsiders to come help solve your problem, you need to solve it on your own. So I ask people to, please, you may want to circulate that across to all the participants of this call. Dr. Yaya Kolade, now that you have so much money to spend, 100 million naira from REDISSE, almost $1 billion in the next few weeks, you have guaranteed us that there will be transparency and accountability when you spend the money. You have shared with us the things you will use to do with the money. I do hope you will also expand collaboration with the private sector in doing so. What will be your last words if you go back to Dr. Fahmi to say, yes, you spent time attending this webinar? What will be your key messages to him?
Basically, my answer will be very similar to what Dr. Abdul Wahab said. Increase funding to the healthcare system, strengthening the healthcare system. This 1 billion naira, whatever it is being called, the COPREP, this is my take on it. The World Bank should enable the states to use it for things that will actually strengthen the healthcare system, not just consumables, things that will be left, things that will have to come back to use again and again, not just saying to be buying PPEs and buying VTMs, which are very, very important. Training is important, but we need to strengthen our infrastructure. We need to strengthen our human capacity. We need to do a lot about equipment. There are some of our facilities that cannot even, they don't stand at the hospitals that doesn't fit for a clinic. Maybe, from where some of us are coming from, some of these things should be strengthened. We should make it much, much better than what it is now. And that's my take. We need to increase the fund to the healthcare system. And whatever funds we are being given should be used to strengthen the healthcare system, not just for consumables. That's what I would say.
Thank you so much. Thank you. I appreciate that perspective. Dr. Ajiboye, last words. Now, money is coming through the door to the states. You've emphasized transparency and accountability. But in the long term, what would take us over the what would take us over the line in terms of guaranteed financing, from your perspective?
Thanks, Olumide. Yeah, I think, I want to agree with the earlier speakers, Zure and Dr. Chikwe, that, public financing is crucial, and the long-term solution lies in, allocation and release of more funds for the health sector by the government. This needs to be front and center of all of the discussion. In the interim, because these are interim solutions where what is happening now is that the World Bank is providing financing to help address these gaps in public financing, but also to put on the table that the support from the World Bank is not only on financing. Right, there's a lot of technical TA that's available from the World Bank, and convening power to also bring in different actors to align to a common solution. I would also take away from this webinar that, and reassure our managers that we have an excellent partner to work with. In the person of Dr. Chikwe, I admire his commitment and his vision, as well as the commissioners who have brilliantly articulated the needs at their state level. I'm very, very happy and optimistic that these resources will be judiciously spent. And the private sector as well would also help, in ensuring that, there's alignment on this so that we can all achieve this. Thank you.
So, Zuera, your last word to you. First, on behalf of everyone, to thank Alhaji Aliko and the rest of the private sector group. So please give them our thanks. But then just last word from you, Zuera.
So thank you, Olumide. I will definitely let them know. Thank you for this opportunity to, share a little bit of what we do. In terms of last words, I think I just want us to stay encouraged. There's a lot to do, but I think we have a lot of what it takes actually to make the right decisions and to make the investments that we need to make to help our people. So I'm not feeling discouraged. I just see that there's a big mountain to overcome, but we have what it takes to overcome it. And I just want everybody to stay encouraged, and all of our commissioners in the states and our commissioners everywhere, and the federal government, and everybody, the private sector who's working hard to make a difference. Well done, I think. And, let's just keep it up.
Okay. Thank you so much, Zara. And Dr. Chikwe, I wanted to ask you the question I had for Dr. Liu, but it's a long one. But if you can answer in a very short manner, I know that a lot of the decisions you're making at the NCD is based on data, is based on science. But if you could just give us just a taste of that in 30 seconds. Number two, I have questions on testing. Any plans to scale up massively testing, and essentially what will be your parting shot for us? Thank you so much. Whilst Ekenem gets ready to thank our panelists and everyone on this call. Dr. Chikwe, you have the last word.
All this in 30 seconds. Okay.
Try.
I think, to be honest, when you're building, it's like you're building a lot of the work when you're building a house, for instance, is not seen, right? Those data systems, the capacity at the states. So at the moment, there are things we're doing like rolling out SORMAS, a digital surveillance platform across the state. That is not easily tangible, but if you don't have all of that, you can't really do the data analysis and use science. So we're quietly building systems, not just for surveillance, for supply chain, for all sorts of commodity management, stockpile management, lots of things that we ultimately need to develop the system. So that's going on, and that is essential in order to use science. You can't use science if you don't have the data coming in. On your second point on testing, this is the one area where I can't come out in front of Nigerians next year if we had a problem and start explaining why we don't have enough labs. So we're working very hard with the states, because this is not something that can in any stretch of imagination be achieved without active collaboration with our state governments, state governors and honorable commissioners. So we're working with them. In the short term, we are 5 states away from covering every state in Nigeria for the immediate challenge. But this is just the immediate. Ultimately, we want every state in Nigeria to have a well-kitted molecular lab that can diagnose COVID, Lassa, yellow fever, whatever infectious disease threat they have, and then build a network themselves around the states. And finally, you said my final word. I just want to say that the work ahead of us will require courage and perseverance. It will require courage to make very difficult decisions, to fight for the resources and delivery that needs to happen over the next months and years, but also the perseverance. There are no magic bullets. I keep using it. It almost sounds cliche. There are no quick wins. You've got to really stick with the ball, and improvement appears over time. But there's nothing, if you give me a X amount of money now, I say, okay, go and solve the problem. You can't train a molecular diagnostician in a week. You know, you can't set up a supply chain system that works in 2 weeks. You can't develop a digital surveillance system and roll it out across this complex country in a week. So there are many things that require time. And when you want to see everything these days about immediate gratification, you want to see immediate results. And so there will not be immediate results. We need to stick with the ball, just like Zuera said. Don't give up, keep pushing, and ultimately we will get to where we are. But we need that courage to make big decisions now and the perseverance to take it into the future. Over.
Thank you so much, DG NCDC. Mr. Economy Ziche, this is the third webinar. These webinars are becoming the place to go for state-of-the-art information on COVID. This has addressed financing, and I hope it's been useful to all our guests. So thank you for hosting us. Over to you, Dr. Economy Ziche. You're now a doctor.
Thank you, Olumide. I don't have my PhD to back it up, but thanks for the opportunity. First of all, let me thank every single person for attending this webinar. Thank you for taking the time. We took 2 hours of your time, and I want to say thank you for giving us the opportunity to do that. This is indeed our third webinar, but it doesn't mean our last webinar. We have a lot of work to do in Nigeria, so this is part of this journey. Let me first of all thank Dr. Olumide. You did an excellent moderation. You kept it exciting and engaging, and you asked some really tough questions. So, but once again, thank you for the great work you're doing at the IFC, and especially in the healthcare sector. Thank you so much. I would also want to thank the honorable commissioners from Ekiti State and from Cross River State, Dr. Moji. Thank you for all the great work you're doing in Ekiti State. We've also seen the inflow of FDI coming into Ekiti State, and thanks to the great work you're doing there. Dr. Betty, great work in Cross River State, and the leadership role you play with the commissioners in Nigeria. Dr. Abdul Wahad, the great work you're doing in NGF. It's not an easy thing managing big stakeholders like governors, but you need all the support you can get, and I think everyone is behind you in some of the work you're doing. To my big sister Zuera, the CEO of the Aliko Dangote Foundation, you may not understand the great work she has put into the sleepless nights, managing funds, doing all just trying to see how they can come together as a private sector and work with government to sort of mitigate some of the challenges we're currently having in the healthcare sector in Nigeria. And I also want to give a big, big standing ovation to Dr. Chikwe. You may not understand, this gentleman has worked tirelessly, sleepless nights, doing everything he can just to mitigate the issues here in Nigeria. And I want to honestly say thank you, Dr. Chikwe, to the work your team are doing at NCDC, and not just in the Abuja office, but across Nigeria to help, address some of the challenges that we're having. I also want, she was a speaker, but she was on the panel, which is Dr. Zina Bagudu, the wife of the Kebbi State governor. She's a big health proponent and all the work she's doing in Kebbi State. And I want to really say thank you to my ACIOE team. You may not understand, these guys have worked tirelessly, from Doyin to Bami to Chinan to Jennifer and all the rest of the team who do act. You may not understand, there's a lot of work that goes into planning. Thank you! And also, you can turn on the videos now. Then you also think about it's a lot of work. So my parting thoughts really is just that our panelists have done a lot of work on the federal and state level, and they've done it with a lot of support from institutions like the World Bank, the Bill and Melinda Gates Foundation, and we're also seeing support from organizations like Unilever, Rike Bankiza, Private and Procter & Gamble, Johnson & Johnson, even Abbott. So everyone is trying to put their hands together to see how we can really mitigate some of the challenges we have. But I'll say this, we all have our part to play. It's something new that I don't think anybody has ever experienced before. So let's make allowances if we do make some mistakes, but we shouldn't make too many mistakes. But every naira, every donation counts and makes a big difference. And don't stop. Wear a mask, wash your hands, protect yourself, and protect everyone around you. Thank you very much. Over.
Thank you.
Thank you. Bye-bye.
Thank you.